so I have no conflicts of interest. So a few years ago, we decided to build our own CART19 construct. So what we did was we replaced the extracellular domain, the antigen binding domain, the FMC63, and we replaced that by our own anti-CD19 monoclonal antibody. It's called A3B1. And the rest of the molecule is basically the same molecule that UPenn was using at the time, CD8 transmembrane, 41BB, and CD3. So we put that into a lentiviral, and we were lucky to have this facility in the University of Barcelona where we could produce these lentiviruses in GMP conditions. And then for the cell production, we used Clinimax Prodigy. This is a system that is a closed system where you select cells through CD4, CD8, and then you activate them with a nanomatrix called Transact plus IL-17 and IL-15. Once we completed all the preclinical work and all the validations, we got the approval by the Spanish Medicines Agency, and that was in May 2017. And this is a bicentric clinical trial. So a portion of the trial is done at our institution, Hospital Clinic, for adult patients, and we have another institution, Hospital Sant Joan de Déu, and they take care of pediatric patients. So this is a pilot, open-label, non-randomized prospective clinical trial. The target population is patients with relapsed refractory CD19 positive B-cell malignancies with no therapeutic options and a life expectancy shorter than 2 years. The primary endpoint was safety. This was a first-in-human trial, and this was determined by procedure-related mortality and grade 3-4 adverse events. And the secondary endpoints we had overall and complete response rate, progression-free and overall survival, RE1 cell survival in vivo, quality of life. And the initial sample size with 10 patients, with the first 10 patients we didn't have any major safety issues, so we amended it to 39. So inclusion criteria, we have mostly treated patients with acute lymphoblastic leukemia, so I will only refer to those patients. For ALL, we basically were happy to accept patients who had relapsed after allogeneic transplantation or who were considered ineligible for that procedure. The age limit was from 2 to 80 years, and the other inclusion-exclusion criteria are pretty standard. Let me just highlight the fact that we would allow patients who had a history of CNS involvement, but not a gross CNS involvement at the time of inclusion. And of course, we would admit patients who had relapsed after allogeneic transplantation. Of course, if the patients had active GVHD requiring immunosuppression, they were not allowed to get into the trial. So for CRS grading, we used what we had at the time. We had this Lee classification published in Blood in 2014. And I'd like to highlight the fact that according to this classification, tocilizumab was indicated in patients with grade 3 or 4, or in patients with grade 2 who had advanced age or comorbidities. And grade 3 CRS in this classification means hypertension that requires multiple pressors or high-dose pressors, and hypoxia requiring more than 40% oxygen supplements. So these are the patients we've treated so far. We have recruited 28 patients, and as I said, most of them were patients with ALL, 23 patients with relapsed refractory ALL, 15 adults, 8 kids. As you can see, almost 90% of those patients had relapsed after an allogeneic transplantation, and even 3 of them had relapsed after 2 allogeneic transplantations. And a number of patients had also received inotuzumab and blinatumomab. So the median age of this population was 23 years old, a range from 3 to 54, and 43% were female. 16 patients, that's 70%, had active disease at the time of inclusion, while 7 were in complete remission. And we had no screening failures, meaning all patients had at least 150 CD3 positive cells per microliter in peripheral blood. So in terms of production and dosing, we successfully prepared these cells in all patients, but it's true that we needed 2 attempts in 4 of them, and that comes up as a 15% production failure rate. This is something that happens from time to time. Reasons for these production failures were bacterial contamination in some cases and transduction failure in one case. The conditioning regimen was the one that is used by the Fred Hutchinson. It's fludarabine 90 milligrams per meter square total dose, cyclophosphamide 900 milligrams per meter square total dose. The RE1 cell infusion was given on day 0 on single fraction, and as I'll explain in a minute, we changed that over the course of the trial. And the dose ranged from 0.5 to 10, although in reality it's ranged from 0.5 to 5. Pre-medication was pretty standard. So these are results in terms of safety. So for the first 15 patients, we observed cytokine release syndrome in 10 out of 15, that is 67%, and it was grade 3, 4, and 4, that's 27%, all requiring tocilizumab. We also observed mild neurotoxicity, grade 1 and 2, in 2 out of 15 patients. We weren't really that concerned about neurotoxicity with our product, and none of these patients, none of them required treatment. But what was really striking to us was out of these 4 patients who had severe CRS, 3 of them died. 2 died of grade 4, well actually grade 5 CRS, and 1 died of a pseudomembranous colitis. Was a fatal complication of a grade 3 CRS. So when we had this problem, we convened our Data Safety Monitoring Board, and we discussed at length what has happened. And one of the members of our DSMB is Shannon Maud from UPenn, and she highlighted that, you know, we've seen similar problems, we've had similar problems where we're treating adult patients, and what we're doing is we're splitting the dose, and we wouldn't give the whole dose on day 0, so we would give 10% on day 0, then 30% on day 1, and then 60% provided the patient remains well. So, so that's what we did. We changed that, and the other thing we did was we allowed for tocilizumab infusion on grade 2 CRS, so we wouldn't wait until the patient was so ill. So with this fractionated every 1 cell administration that I just mentioned, so the idea is, again, you give just a little bit. If nothing happens, you carry on. If the patient develops fever, tachycardia that resembles CRS, you stop, you give no more cells. And this early administration of tocilizumab, so grades 3, 4 CRS appears least frequent, so as I just said, 4 out of 15, 27%, whereas with the new way of giving the drug, we've had no cases of grade 3, 4 CRS, 0%. And neurotoxicity remains infrequent. I'm just going to briefly comment on a case of neurotoxicity because at least with our product, the neurotoxicity is kind of different. So this is a 31-year-old male who had a typical case of ALL referred to us, relapsed after allogeneic transplantation, and he was given RE1 cells. And then on day 6 he complained of headache, grade 2, then nausea, vomiting, and then on day 8 started on cytokine release syndrome. We were not that concerned, but then on day 10 he was complaining of blurred vision, and then he had a sort of nystagmus. So we performed a lumbar puncture and we observed there was an increased number of mononuclear cells in the CSF and also increased number of proteins. So we performed, in this lumbar puncture you can see the activated T cells, and most of the cells there, 73% of those cells were T cells, lots of monocytes as well, 22%, but more worryingly, 0.5% of blasts. We weren't expecting that. 85% of those T cells were actually CAR T cells. We did nothing. The patient actually improved spontaneously, and on day 15, so 5 days later, we repeated the lumbar puncture. Still lots of T cells, but the CAR T cells were less. There were no blasts left, so those CAR T cells got rid of the residual leukemic cells. And the patient was discharged and he remains in remission. So in terms of efficacy, 16 patients have measurable disease, 2 patients have not been evaluated yet. The complete response rate is 71%. 7 patients were already in remission at the time of inclusion, and they all maintained their response. All patients develop B-cell aplasia, but roughly half of them recover B cells around 3 months. Duration of response with a median follow-up of 8 months. We've seen some relapses, I'm afraid. We've seen 5 patients with CD19 positive relapses. All these patients had lost CAR T cells and recovered normal B cells. And we've also seen 2 CD19 negative relapses in patients who still had their CAR T cells circulating. With that, I'd like to conclude. It was feasible to manufacture RE1 cells for these patients in a timely manner. These cells were functional, as evidenced by this universal B-cell aplasia and a 70% complete response rate. Neurotoxicity was infrequent and mild, and it looks more like RE1-induced meningitis. CRS was frequent when we started the trial, but it looks like we've managed to reduce that risk. And we are actually considering to apply for a local national approval under the hospital exemption rule, hopefully in the autumn this year. I would like to end by acknowledging all the people involved in this trial, and of course all the referral centers all across the country and our funders. Thank you very much.
Thank you, Dr. Delgado. The presentation is open for questions.
I have a question. Actually, all the CAR T cells that you infused were donor cells then, right?
Yeah, well, most of them, yeah, because 90% of the patients had relapse after an allogeneic transplantation. And if you worry is GVHD, well, we've had one patient who probably had some sort of skin GVHD, and then we have another patient who had some sort of hyperbilirubinemia, and we were thinking maybe this was liver GVHD, but in the end it was something completely unrelated. So no, we haven't had that problem at all.
Thank you very much. The next presentation